Yeah, yeah. Thumbs up. Oh, ish, only ish. Okay. This is a really deep room. I'm Mike Cull. I'm with the Center for the Helping Professions. Some of you in the room I know. I worked at DCS for a while, and I worked at the Center of Excellence at Vanderbilt for a while. So I've kind of been kicking around in Tennessee for a while. This is a new center. We just opened in Tennessee to do some of the work that we're going to be talking about today. We adjusted a little bit what we had planned today. So I'm going to go through a few slides to introduce the National Partnership for Child Safety to you and talk about some of the data that we're starting to see. It's a national collaborative that shares data. And then we're going to have a little panel discussion with Austin Wouters and Mary Beth Duke, who a lot of you probably all know. So I'm going to have them come up after I go through a few slides. Hopefully you guys this will work. And we might need to slide the chairs out there a little bit. And hopefully I'll leave plenty of time at the end for questions. So I'm going to be talking about the National Partnership for Child Safety. The National Partnership is a national quality improvement collaborative. It's anchored to sharing a standard set of data from child welfare systems, fatality and near fatality reviews. It's modeled after similar quality improvement collaboratives from other safety critical settings that I'll describe in a little more detail. The work actually started in Tennessee. I know some of you know that history, but if you don't, the work of applying safety science in a child welfare context using kind of a systems approach or root cause analysis approach to reviewing critical incidents, in particular fatalities and near fatalities, all that work started in Tennessee. It actually started probably in 2014. We started doing some of the work. Many of us were at Vanderbilt in the Center of Excellence, and we were kind of applying some stuff that hospitals use in the interest of patient safety into the child welfare setting. And that started with applying kind of a root cause analysis or systems approach to reviewing child fatalities. Grew beyond that to a lot of the other work that I'll describe, but that's where it sort of started. That was the origins. And in 2018, we had a summit at Vanderbilt where we invited, as the work kind of grew in Tennessee and people started getting interested in it from other jurisdictions around the country, they would come visit or we would take a team out and visit them. So we, in 2018, had a summit here in Nashville, brought in actually 20 jurisdictions at the time, and kind of had some speakers, but mostly did some working sessions to kick off this idea of creating this national quality improvement collaborative. Around that time, there was a national presidential commission on the elimination of child abuse and neglect fatalities, and they had gone around the country taking testimony on promising approaches to reducing or developing prevention strategies around reducing child abuse and neglect fatalities. They met with us in Tennessee. We gave testimony to the commission, and our work made it into their final recommendations, where they recommended that we do a pilot for applying safety science in child welfare context. This came out in 2016. So instead of piloting it, coming out of that 2018 convening at Vanderbilt, KC Family Programs is a national nonprofit that works specifically in the child welfare space, funded what became the first cohort in this national quality improvement collaborative. And it was 8 jurisdictions that came out of that first 20 that we had sort of done a needs assessment on. Tennessee was one. Are you kind of ready to go do this work? As I said, it's modeled after similar quality improvement collaboratives in other safety critical settings. And so it really, starting this work initially kind of from Vandy, was that just this simple recognition that, like surgeons and ER nurses and pilots in aviation, our child welfare professionals are making high risk, high consequence decisions all day long. And so they might benefit from some of the same strategies that we see in other safety critical settings that help those professionals be more safe, effective, and reliable. And it started with kind of what are these anchoring things that we could do? And the anchoring thing for us was let's work on child fatalities and bring this systems approach. There have been other people nationally and internationally had started kind of calling for bringing that kind of approach to looking at critical incidents. So it's kind of timely and a lot of things kind of converged at just the right point. There's a couple of reasons for anchoring it to the review of fatalities. One is bringing a systems approach helps us learn about our system. Like it's something we should be doing. Prior to the national partnership, it wasn't uncommon, and it still is the case in a lot of places nationally, for the internal reviews of child fatalities and child welfare systems to be fairly cursory, retrospective reviews, maybe a reinvestigation, but rarely like a look at the system's role in the case, looking for sort of a quality improvement opportunity in the face of these kind of high profile tragic events. The other reason is we historically in child welfare and across the public sector and historically in other industries like aviation and healthcare, the response after an event, a critical incident like a fatality or near fatality, could be reactive and punitive. It could be about shame and blame. And again, rarely about looking at opportunities to learn and improve your system. And so what we know happens in child welfare in particular when we have an approach like that, high profile fatality, you guys have all lived through things like this probably, high profile fatality, media reaction, legislature wants to pass new laws, somebody's got to be held accountable. We see our child welfare professionals go underground, they become more conservative, and they're much less likely to trust reunification efforts, to trust preservation efforts. They're much more likely to bring a kid into care because it's the safer professional decision, right? If I take them into care, they're safe. And so we see custody numbers spike after those high profile events. So there's a couple of reasons for starting with fatalities. One, they're important. Two, we can bring this new systems lens and learn differently about our systems. But three, these low base rate events can have an outsized impact on our culture. And what we want to build is a specific kind of culture because we know culture really drives how we do our work. Culture is about sort of our team habits and how we solve problems. And so what we're trying to bring is a different problem-solving lens that can inform a different set of team habits. That's sort of the thread to the work that anchors it in building what other industries call a safety culture. So we're trying to sort of create this thing called a safety culture in a child welfare context. The other reason for anchoring it to fatalities is, as I said, and this is consistent with those other similar collaboratives that you see in other settings, like a really well-known example is NISQIP. It's run by the American College of Surgeons, and most operating rooms in the country or hospitals participate. And they share data, safety-related data from their operating room. And so the idea is things like a retained foreign body, like a sponge getting left inside a patient, doesn't happen very often. So it's really hard for one hospital to learn from that event. So they share that information across a large number of hospitals so they can get at these otherwise inaccessible learning opportunities. And I'm going to show you some of the data that we're starting to see from the national partnership, because that was sort of the idea behind let's anchor this to these systems reviews of fatalities. They're fortunately rare events in most child welfare systems, all child welfare systems. Hard to learn from them in isolation. Can we figure out a way to do a review that allows us to get standard data that we can share across the country? So as I said, we brought 20 jurisdictions to town in 2018. 8 of them started in the initial cohort, and we're at 40 now. So from 2018 to now, we've grown to 40 child welfare jurisdictions. It covers about 65% of all kids in public child welfare. So it's grown really rapidly. It's a really nice mix of, so you should be very proud. The state of Tennessee is the reason this work's being done nationally. It's a really nice mix of state-run systems like Tennessee's and county-run systems like LA or the counties in Ohio and Pennsylvania where the system's organized a little differently, where they're sort of state-administered, county-run. Nice geographic mix. We add a jurisdiction every couple of months, so it's really growing quickly. We just added Rhode Island, so we have all but Massachusetts in the New England states. So it's a really, really, really nice group of child welfare systems really leaning into this quality improvement approach. And we, Austin was there, we were able to get all but one of them together in Chicago in the fall. And it was a really, really nice, exciting meeting. So I'm going to go through some of the details of kind of the review process, how we collect the data, and then some of the things we're seeing from the data, because that's what's really become unique about this work. And then I'll show you some of the kind of the outcomes. And we're all early days. Like this is very much, as I said, we started in 2018. There's a ramp up for all these jurisdictions. And then you guys are well aware of child welfare systems. We have a lot of disruptions. We'll lose a commissioner or a director somewhere, and the team will turn over, and we kind of got to start over. So it's very much developmental. A little over half of those 40 jurisdictions are at the point where they're actually sharing data. So I think importantly, prior to the partnership, there was no best practice approach to reviewing child fatalities in a child welfare system. Generally speaking, there's three kinds of fatality reviews that go on in any given state. The CDR teams, those multidisciplinary teams that are usually overseen by the Department of Health or the medical examiner. The child welfare system typically participates. It's usually from somebody from like investigations or CPS in our system. Those reviews are done sort of from the perspective of epidemiology. It's like an epidemiologic approach to looking at fatalities and near fatalities. So they're really doing a deep dive into the cause and manner, the circumstances around the fatality. Then there's reviews that are typically done by like a citizens review panel or do we still have a second look commission in Tennessee? Like that external, a child advocate, someone like that external entity that their view into the system is really about public accountability. They're looking into the child welfare system, typically at a subset of reviews. And their lens really is about public accountability. And then there's the third bucket, which is the one we work with, and that's done from the perspective of a quality improvement lens. It's this tragic thing happened, this event happened in our system. How can we use it as an opportunity to learn and get better and prevent the next similar situation? So prior to bringing all these jurisdictions together, there wasn't a best practice approach to doing these reviews nationally. Everybody did them differently. Importantly, the people that did those reviews, and no one should have to do those reviews, no one's job should be to review child fatalities, but those professionals weren't connected to any other professionals nationally doing similar work. And that's not the case with those other reviews that I described to you. Those CDR teams are very networked nationally. They get together, they have conferences, they share best practices. So all of these reviews were very much being done in isolation. Most jurisdictions didn't database their reviews. They would usually result in sort of one report about the fatality itself, or maybe there was a spreadsheet with some information on it, but it wasn't a rich database of information like I'll show you in a second. So now we have 40 jurisdictions all doing an approach, not exactly the same, but we bring a set of principles and we kind of wrap it around what the jurisdiction needs. So all jurisdictions are a little different in their policies, in the statutes that govern the reviews they do. Some jurisdictions have, LA County has a whole division of people dedicated to this work, and Arkansas is one. So we have to be very flexible in how we fit the principles of these reviews around the jurisdiction's needs. But generally speaking, they all follow this pattern. The critical incident happens, as you would imagine, a record review needs to happen next. That's where most reviews used to stop. They were retrospective. You just looked back at what happened and you looked for, things that you thought were important that got missed or didn't happen in the case or could have happened differently, and then you write up your findings. What that makes you really prone to in any kind of review is hindsight bias. This idea that once I know the outcome, child fatality, when I look back at the record, I'm really prone to put all the stuff that I see in there together in a way that didn't emerge when people were actually doing the work, right? They didn't know when they were working the case that at the end of the day, the fatality was going to be the outcome. So the way to combat that is to understand what we call local rationality. This idea that people make decisions when they make them because it makes sense to them at the time. Otherwise, they'd make a different decision, right? Not a value judgment, not that their decision was good or bad, just that when they made it, it made sense for some reason. So the only way to combat that is to go talk to people. So we try to build out models where we do the record review and we have sort of a structured way of thinking about the information we pull from the review. And then we go meet with folks who are actually involved in the case or proxies for the people who were involved in the case if we can't get access to them. But we have, an approach for going and doing a supportive debriefing of the people that were actually doing the work. And then we aggregate the data. We put it into a database. We are able to build out databases for the jurisdictions using REDCap. If you've been around the system, you guys use REDCap for a lot of different quality improvement projects. So we're able to build these really nimble, lightweight kind of databases that we can just give to a jurisdiction so they have the capacity to do this. And then that allows them to share data. And then we use a tool that we developed called the Safe Systems Improvement Tool to standardize the output. And is everybody, by show of hands, familiar with the CANs? Because you're in, Tennessee was also the first state to implement the CANs statewide in child welfare. Do you guys know that history? I know you do. So The SSIT, we worked with John Lyons, who developed the cans, to develop that tool. So it would look very familiar to you, and I'll actually show you kind of an example. If you were familiar with the cans, you'd be very familiar with the structure of the SSIT. It differs in that the cans helps you understand important information about a kid and family's depression or substance abuse needs or abuse related stuff. The SSIT helps you understand important information about your system, like workforce stress or fatigue or production pressures or a gap in teamwork and coordination, which I'll show you some information. So reviews get done using this sort of the principles and this kind of best practice approach. They get standardized into a database using this tool, and then we share them nationally. Really, really critical to this work. And I talked about this idea that what we're really trying to do in learning from these things is also like inform our culture. When you're talking about where culture lives, it lives in your habits and how you solve problems. And these are the biggest problems. And so if we can infuse this way of thinking into solving these problems, the theory goes, we can help the system think differently kind of throughout how your teams organize and work. Core to this is understanding psychological safety. We want to, at all levels of the system, build up psychological safety. And it's really critical, starting with those reviews, these really high-profile events where trust can really be broken down inside a system, that you build into that approach that I just described, methods for supporting psychological safety in your conversations. And psychological safety is just this idea that I feel as a professional that I'm accepted, I'm respected, I feel like I'm part of a team. But importantly, I can speak up, I can be candid with other professionals, I can give them feedback. And we treat mistakes on our team as opportunities to learn, not opportunities to punish. So that's kind of the essence of psych safety. It's not a freedom from accountability, and it's definitely not comfortable. Those things I just described are hard. It's hard to speak up and candidly give another professional feedback. It's hard to feel safe speaking up when you've been involved in a case that didn't go the way you would have hoped, where there were mistakes made. But that's the kind of context we have to create if we want people actually talking about problems in our system so we can go fix them. Because the opposite of that is people don't talk about problems. And it's not that problems don't exist, it's that people don't talk about them. Amy Edmondson did the initial work on psychological safety. She did it across nursing units in the Harvard system. And her charge was to go look at the relationship, if there was one, between error reporting. Hospitals are required to report things like medication errors and falls and things like that. Error reporting and outcomes on units. And I guess the hypothesis going in was probably that when we see more errors on a unit, we get worse outcomes. They saw the inverse. They saw when hospital units reported a lot of errors, they actually got better outcomes. So they went back in to figure out why. And this was sort of the construct they defined, that those teams that were comfortable talking about things when they happened on their units actually fixed them and got better outcomes. So lots and lots of research across a lot of industries about the importance of building this kind of dynamic into your teams. So this is really quickly what the tool looks like. I want to go kind of quickly through these slides so we have plenty of time to have a conversation. As I said, if you've seen, and again, we build this into a database, so you're not actually scoring it on paper, but if you've seen the cans, you're familiar. What I wanted to point out is that we like the cans break it into domains, but the domains are nested domains, and that's important for the way you think about the data. So it's a child and family. We use a set of items actually that come from kind of adaptations from the cans in the FAST. So it's a family nested within a professional, nested within a team, nested within the broader environment in your system. So the data is kind of nested in that way. And that's important because when you're looking at something from a systems perspective, you don't want to stop down at that professional inaction or action level. You want to push yourself in a review process to think up and out through your system. Think about that professional's actions within the context of a team, supervisory support, for example, or supervisor knowledge transfer within a context where we have policies. We have what's called demand resource mismatch, which is like, did the folks have what they needed at the time that they had them? I mean, they needed them rather. So we very much try to build a process that forces a conversation up and out through your system, doesn't just stop at what did the professional do or not do, what policy was followed or not followed. The data then is structured in a way that gives us the opportunity to look really deeply at qualitative data and match it to our quantitative data. The CANS is that way too. We don't think about it that way enough, probably. But the way that you rate any of these kinds of tools, these communiometric tools that John developed, is you find something that you want to rate actionable, depression, you rate it at a 2 or 3, and then you justify it with a little bit of narrative. This is why I think depression was actionable. What that does is, from a qualitative data perspective, it pre-categorizes all your qualitative data. So now you already have that narrative categorized as depression. Whereas if you were just doing a qualitative analysis on a written report, your approach would be to then go categorize it in those ways. So you kind of have the head start on looking at the qualitative data. So that's how our data is structured. We have the qualitative data that we define as an improvement opportunity. We went back and did the record review, and we saw opportunities to improve. And we define that as a gap between what the family needed and what they got. So we did the record review. Substance abuse was a big issue. We weren't able to really connect them with substance abuse services, or they were inadequate. We see that as a gap. And then we're going to rate the tool based on those gaps. It gives us quantitative data that we can analyze, and it gives us a lot of good, rich qualitative data that we can analyze. And I'll tell you that, and I'm going to show you some of the, well, I won't say that now. So I think I said, so we have 28 jurisdictions now that are have fully developed their process, and again, most of these jurisdictions, it was either a greenfield build, like we walked in, they didn't really have anything. We were able to work with them just to build up the process, or it was us fitting into their existing process and, sort of some new tools. From 2023, we were at 19, we're all the way up to 28 now. In our data, actually, and these are from October, these slides, so it's going to be, we would have had one more quarter of full data. But 711 reviews, 1,800 improvement opportunities. So as tragic it is to talk about, it would take Tennessee a long time to get 700 child fatalities standardized and into a data set that they could analyze and trend, right? So just in the span of not really a year, because again, developmentally, and we're just at the point where a lot of jurisdictions are starting to share data. 5 years down the road, sadly, we'll have a good sized number that we can look at. And our data, again, it differs from like a CDR review, where it's not a lot of data about the cause and manner of death. In some ways, the event is just a window into your organization, because what we know is the practice that we see around a fatality doesn't really differ from practice that you might see on any other case, right? It's just the outcome that's very different. So it gives us a window into the system, and then we bring this kind of root cause analysis approach. So we're learning things about your system in a very specific way. So that makes it a really unique data set. And again, it's going to reach numbers that any one jurisdiction, it would be impossible, fortunately, for them to reach that number. The top 3 causes, of course, our SUA deaths are by far the most frequently occurring fatalities that we see around child welfare systems, followed by poisoning and overdose and physical abuse. Just a quick glimpse at this. This is a lot to look at. Just a quick visual, though. The column over here, the U.S. population kid count, that just shows you the typical demographics in a child welfare system compared to our SUA poisonings, physical abuse, and then all other cases. And the thing to just kind of quickly look at is there's not a lot of difference in just like the demographics that we expect to see versus demographics that we see in fatalities, except for in a couple of key areas. Physical abuse tends to skew a little older. Of course, the SUIDs are all under 1. What was the other one I was going to point out? Male on physical abuse is skews a little bit male, and on all other category. In terms of the race demographic, I think it's that overdoses skew a little white, physical abuse skews a little black. We don't have very many other races actually in the data yet, so it's a little difficult to see. But the demographics that we see in the fatality data, except for in a few cases, isn't a whole lot different than we would expect to see just in demographics of kids in child welfare generally. Okay, some of the data. We take the scored items, we report out frequencies, and then we're starting to do some analysis on the qualitative data, and we're starting to link that stuff. And so I'm just going to kind of build through that and have a conversation about what the data's starting to tell us and what things we're finding interesting in the data. Across all those reviews, as I said, SUIDs are happening more frequently. These boxes are the items from the child and family domain on the tool, right? So these are the items that are about the child and family. And the way we rate it, for obvious reasons, when I say it out loud, unlike the cans and the fast, is you're not rating like a future need or an ongoing need because it's a fatality. It's sort of allowing you to contextualize the family at the time of the event. So this is the need existed at the time of the event. It's not about sort of future needs because for obvious reasons. So when we see, and then the bars are the different types of child fatalities. So when we see SUID deaths most frequently occurring, we see caregiver substance abuse as a really big deal in SUID deaths. Not a surprise to anyone, right? What's interesting about this, and I think important for our field, is we have data now. We have data that's different than data we used to have. And the example I always used when we were trying to get this off the ground is in hospitals. We know that one of the big patient safety vulnerability points is points of communication, and especially like transfers of care. So shift change, the handoff between the ER and the ICU, nursing reports. Those are the places where information gets missed and create these vulnerabilities for. We didn't know that until we started doing root cause analysis and sharing the data nationally and doing stuff like this. And now it's just like accepted wisdom, and it's like, duh, of course those are opportunities for improvement. We didn't know that. And it caused hospitals to change a lot of things about the way they do their work, how they standardize communication, how they overlap shifts, how long they let people stay up, things like that. So having this data is going to, I think, change the conversation, and having the ability to do analysis on the qualitative data, I think, is fundamentally going to change some opportunities to improve our practices. Parenting behaviors, most frequent too when we see SUID deaths. Family conflict in physical abuse, again, not unexpected. But then again, within this, we're going to have a lot of rich qualitative data to go look at. And I'm going to show you some examples. Any questions as I know I'm kind of cruising through data slides quickly. But I'm doing it sort of on purpose because I don't want you to get lost in the data. I really wanted to introduce you to the partnership, remind you if you didn't know, or tell you for the first time that Tennessee was a huge part of this, and you guys should be really proud of that. And it's grown into this really important national collaborative effort. An important thing about what it's grown into and how we designed it too, and I think this can't be said more strongly, is we intentionally designed it early on to be member-owned, member-directed. It's about peer-to-peer learning. It's not an external accountability model. We've got tons of folks holding us accountable outside of our systems. We needed a space where child welfare systems could come together, learn safely from one another in a peer-to-peer model. And that's been a huge win early on. As I said, we brought almost all of the jurisdictions together in Chicago back in October. So we didn't know, we obviously couldn't have known. When we started this, we knew we were going to have a lot of qualitative data, and we were going to have a need to do analysis on that data. But when we started doing this work, 2018, qualitative analysis was aided by some tools, but it was also a lot of just like brute force going through information and categorizing it. And we're like able to do so much more with all the large language model, AI enabled sort of natural language processing tools. So we have a colleague at Northwestern who, like, this is his thing. We give him lots and lots of words. There's over 1 million words in our data set now, and he does just incredible things with it. And it's early days. Like what we're able to do now, it's hard to even imagine as quickly as the technology is advancing, what we're going to be able to do, 6 months or a year from now with these qualitative data. So that's huge, because thinking back again, much of this information would have lived in just an individual report. And we're still there, where a lot of times, child advocates or those kinds of folks in our systems will release an annual report. And that information is not getting put together with other information. It's oftentimes not quantitative, so it's hard to put it together, but it also just sort of lives in isolation in any one state. And so our ability to bring this information together and bring these new analytic techniques to child welfare, I think, is going to be super exciting. So when we start looking at themes that we're seeing in the qualitative data. So now I'm moving you from thinking about, I think, in fact, I missed a slide. Oh, that one. I didn't talk about that one. So I showed you some of the most sort of like the frequencies, the most frequently occurring stuff that we're seeing in the child and family domain. This is the systems items. So that's these nested items that, again, like the cans capturing information about depression, they're capturing information about important systems things like, what was the role policies played, or what was the role fatigue in your workforce played, or cognitive biases. It's capturing these things that go on in a case, in a critical incident, that are systems influences. By far the most frequently occurring, not by far by number, but it's both the most frequently occurring and the most stable across reviews. So meaning LA County rates it a lot and South Carolina rates it a lot. It's not the case that one jurisdiction is doing it a lot and some other jurisdictions aren't doing it very often. It's a really stable finding across jurisdictions and really frequently occurring in cases is teamwork and coordination. It's one of our system items. It's happening at the team level. So again, these nested domains. And it's teamwork and coordination can be defined either teamwork and coordination within your system. So how people are teaming on their team, or how the foster care workers and the investigators are teaming, but it also can be teaming outside of your agency. Because again, when you rate it, you're writing a narrative. So we can write about teaming and coordination from a couple of different perspectives. By far, the most frequently occurring things that we see inside teamwork and coordination is not teamwork and coordination inside your system. It's external to your system. It's teaming with law enforcement, with education, with healthcare, with mental health. Again, not surprising, right? But we didn't have data that said that before now. And we're starting to get a lot of data that says that. So most frequently occurring inside those systems items is teamwork and coordination, stable across jurisdictions. I already talked about this. We're taking all that qualitative data out of those reviews and we see them identified, and we're putting it into this model. When we look at teamwork and coordination as an example, so pulling that one that we're seeing a lot out as an example, the themes that emerge, the most frequently occurring merge is this one, community services coordination. And this is like sort of broadly coordinating with community agencies. If we group these three, though, if we look at law enforcement interaction, medical provider interaction, and school interaction, if we group those, because again, what I like interacting with these agencies is what we see the most frequently, that becomes then the most frequently occurring item. So if you think about grouping how we interact with those important agencies, law enforcement, education, and medical providers, it's the most frequently occurring problem that we see in child fatality cases, is teamwork and coordination with these other entities. Then the improvement opportunities we see associated with this are we broadly grouped into when we went through, and then that's those things, that gap that we see between what the family needed and what they got. Broadly defined, the category external communication and collaboration has within it community service coordination, law enforcement interaction, medical provider interaction, school interaction. So this is just demonstrating consistency between what we see in the record review and what we ultimately rate on the items, because the record review pulls out for us these improvement gaps, like what we see as an opportunity to improve our system. So I pulled out, this is just sort of an exemplar. This is the kind of information that we see documented in the narrative, scored on the tool. So inconsistency with law enforcement agencies being willing to provide support to the case managers. So the reason I pulled this exemplar out is because it, in some ways for me, demonstrates the presence of psychological safety, right? It's written in such a way or described in such a way that someone feels safe talking about this, but both feel safe talking about it, but also is identifying a lack of it in the field, like this gap between law enforcement being able to provide the kind of support they need. This is a level of information that you don't get at in like a CDR review, where you're reviewing records on stuff like cause and manner of death, right? That allows us to count child fatalities. It doesn't allow us to understand things like this. Like in the context of this fatality, we were having difficulty coordinating with our law enforcement partners, and this is an example of why, right? That's sort of the thread that we're trying to pull together. And to be clear, this is really complicated stuff to pull together, right? That the reason that we don't do a lot of reviews like this is because it is really complex to get at this level of information in a single review, much less take that level of information and try trended across a large number of whatever things you might be reviewing. So this takes us now to looking just sort of teamwork and coordination linked to some of those improvement opportunities. Again, most frequently occurring are these community coordination issues and collaboration issues and family and child needs. If we begin linking them now together, we see law enforcement again appearing. The only difference between these two this is why in terms of the five most frequently occurring is on the communication and coordination when law enforcement appears. When we get over to family child needs, it's this idea of responsibility overlaps. So just sort of the confusion about who's responsible for what across a complex system. So we know, I mean, this is what I think is important about this information, that it'll allow us to start bringing to the conversation a different set of data that helps us hopefully the broader system understand that the responsibility for keeping kids and families and communities safe and healthy can't fall just to the child welfare system. Like, we partner with and rely on a lot of folks across a lot of sectors. And we can say that and everybody would shake their head and say, yes, that makes perfect sense. We all have our roles, but we don't have data really to support those conversations in the same way that we do now, or that we're getting there. Again, we're early days, so this data is really, really fairly new. And then, yeah, that just definitionally, that's the stuff that we were looking at. And then another exemplar within the communication and collaboration and improvement opportunities, a similar sort of finding. When staff are responding to a child fatality, law enforcement rushes staff during the initial contact, makes staff feel they have to rush to complete the initial contact. Again, describing sort of not just sort of a process finding or a practice finding, but an interpersonal finding, right? Something that would be difficult and challenging to deal with in the field. If this was the dynamic you're dealing with as an investigator, it's challenging to navigate with law enforcement, the pressure they're putting on you and how that's affecting your casework, right? So surfacing this information is really, really important when we're thinking about, why do we see these gaps? Why do we see, maybe incomplete initial contact information? Do we need to write another policy and go train everybody? Or do we need to understand that there's forces out there that are getting in the way of us doing good work? Just one more exemplar, and then I'm going to wrap up and we're going to have a little discussion. This one on the family and child needs. Participants reported that the assessment and permanency teams are divided, unwilling to work together. Both sides are becoming unprofessional, lack of trust with decisions making with the family. So again, we know these things go on in our system. We hear about them anecdotally. If we can surface this in one system and then begin seeing it across a large number of systems, it becomes then a data point that's not just about sort of the failure of one system or one system not functioning well or interpersonal stuff in one system. It becomes something that's systemic that we need to work on from a different perspective. So just two more slides. So the basic idea then is, at the jurisdiction level, let's help systems, identify opportunities to learn, go test change. This is a quality improvement collaborative. So as it gets more mature, right now we're very much on the analysis side. We're building jurisdictions' capacity to do these reviews. I'll show you examples of how this has already started, but as we mature, it'll be much more about supporting quality improvement efforts. So bringing jurisdictions together to actually work on stuff that we're seeing in the data. And then sharing that stuff nationally so we can then at the national level sort of repeat the process. Some of the activities that are going on that are resulting in actual outcomes, we pull together these affinity groups where jurisdictions come together. Again, it's about peer-to-peer learning. We have 4 going on right now, one around safety science in the workforce. One where we're bringing the attorneys in, which I think has been a really interesting dynamic, is the attorneys working in the child welfare space, bringing them in around this idea of safety science. Some intersectionality stuff, oversight agencies, peer-to-peer. Where we're really getting a lot of traction is in these, what we call applied practice communities. That's where we actually take the data, bring together some jurisdictions, and work on a solution. So we've already put out guidance called Safely to Your First Birthday, and that's specific to SUID prevention. So we have kind of a model now that we're putting out around SUID prevention that really pushes us beyond, alone on your back, crib, no smoking. It moves beyond that sort of basic model, and it kind of brings in this idea that there's a human factors gap that we're not understanding, that moms in particular want to interact with their babies in a certain way, and sometimes that sets them up to not be safe. And it's also sort of not been enough to just say alone on your back in a crib, don't smoke. So it brings in a different sort of lens. We're expanding that to safely their 5th birthday, where we're going to be working on overdoses and firearms. Again, we're bringing together the child welfare attorneys, and we're doing a co-design lived experience quality improvement group. So we're starting to do the work of taking the data and translating it into quality improvement work that can result in, and the idea is like, take the data, take a small number of jurisdictions that are interested in working on it, iteratively test the improvements until we get them right, and then disseminate them broadly across the big network. Okay. Any questions before we transition? Okay. You guys want to come up? Should we slide these out maybe a little?
I don't want to stare. It could be. It could be three.
Oh, good. So we just kind of queued up a few questions related to the work that's going on in Tennessee, the work with the national partnerships, and things I think that still a relatively new leadership group is hoping to do. I think we're all comfortable taking questions. If you guys just want to shout out a question or raise your hand or whatever. We've got a fair amount of time, I think, for this part.
Still waiting.
I do have one question.
Yes.
So for the data sets, I know you're still in the early stages of it, but has it been aggregated to reflect urban versus rural populations?
Yeah.
We'll talk about the teaming and the law enforcement. I know in our kind of experience that in rural areas you get better coordination, but they may have lack of training and resources. And
we've done some of that. I can't speak to the team of information. I don't know if we did do that. I just don't remember the analysis, but it's a great question when reflective of like, that's the stuff that we know we'll be able to do. Like that the value of aggregating across a large number of systems is we can begin to have the data. Because again, imagine one state trying to look at the difference between urban and rural on such a small number. Like it starts out small. You start slicing it into states unusable almost. You're cutting it up that way. So yeah, I think we're definitely hopeful we'll do that. I don't think right now we have much of that. Any other questions?
Maybe in a similar vein, I know you mentioned something about how there's some similarities, for example, between like LA County and South Carolina. But have you noticed any differences in systems that are maybe city or county or region based as opposed to statewide systems? Is there anything showing the difference yet?
No, I really haven't seen much at all in any of the data that we look at. It makes those look different. Not yet. The other bit of data that we have a lot of right now, and if you come to the talk in the afternoon, we also do a lot of organizational assessment work with systems. We're looking at stuff like site safety. And similarly, we don't see a lot of variation across systems. We see a lot of variation inside systems, and that's consistent across places like healthcare and aviation too, where the burn unit looks really toxic from a culture perspective, and the ER is killing it. Like you see a lot of variability inside a system, but you compare Vanderbilt to St. Thomas, and they don't look any different, at that level. So I just was talking about site safety. Talk about site safety, and when you guys decide who wants to go first. Talk about how you guys think about psychological safety in this work from two perspectives. One, how do you think about it, the importance of it in these reviews, like on the teams, the folks doing the work, them understanding it and being able to promote it, and then more broadly, how do you see it as, and maybe what are the things you guys are going to be doing or already doing as important to the workforce?
Going off.
I can say for the system reviews that occur, I think one of the biggest components was psychological safety with that piece. is that is sometimes maybe the only time that a case manager is asked, did you feel production pressure? Did you experience support from your supervisor? Rather than the typical whodunit questions. It's sometimes the only time that they really get to say, tell us what was going on with you work-wise. I think that's like when we were in the conference in Chicago, a lot is talked about with psychological safety, with it being non-punitive. But I think there's also a piece of it where the actual review itself is somewhat cathartic in that process itself. And I know that our folks who do those reviews try to do their best to let people know, hey, and this really goes into kind of how we talk to our leadership about this work. One of these is an investigation of who did it and what happened and X's and O's. One of these is an investigation of our system. And that helps leadership see it. That also helps the person who's kind of gone through a rather traumatic experience to be able to say, oh, you're not coming at me right now. You're looking at the broader picture and where I fit into it. So I think that's significant yet overlooked sometimes.
I think that's really important. Both those points are incredibly important. I think our child welfare professionals, this could have been the worst thing that's ever happened to them professionally, and they can get isolated and stew about their role and overstate their role and their ability to come in and be a part of the solution and part of the problem. It's really, really important. Do you guys need to introduce yourselves? Does everybody know? Everybody knows.
I know you're not.
Yes, everybody knows that. But just in case, I am Mary Beth Hughes. I'm the new executive director for statewide prevention with the Department of Children's Services. Title's a little bit misleading because I don't have FSS and I don't have CPS. So, but my work is around court liaisons, kinship care, resource linkage caps, and volunteer coordination. So when you look at it from that perspective, we're trying to get to the court early and then to wrap services around family, whether it's custodial or non-custodial. I don't get near as excited about a kid who comes into care that has a relative, right? Because not everybody can afford to take 4 kids when they already have 4 kids. You can't feed 8 kids. Anybody fed a teenage boy, it don't matter if you've got no children, you're still gonna be broke. So we try to work with them around those services. But for the past 30 years, I have spent in child protective services here with the Department of Children's Services in rural. And I had at one point 2 urban areas. I had Davidson and Shelby. Deshaun was one of my employees. Kind of funny. Now he's one of my supervisors, and I'm perfectly fine with that. Because I know he's going to work hard, he's going to last. Okay. But yeah, I had both, and I had both the rural west. I've heard the name. Oh, what Marie Beth said, that'd be me.
And I'm the executive director of Fallen Clients now, formerly CTY, but I just think quality is the simplest way to put it. But I have the team currently who does the safety system now. So, and I'm grateful to have Mary Beth in her role, her experience where she was and where she is now. I think this tool pushes so much in towards prevention. The answer isn't, well, we got to take more kids out of more homes, like he was talking about earlier. But the answer is more preventative measures. That's why I am. When I found out Mary Beth was going to be in that role, I was over the moon.
He just didn't know any better. I think, when you work in CPS for 30 years and you start the system, that first picture I laughed because Deshaun's at one of those tables and part of my table's cut off, the part I was on. So yeah, those pictures, we were all in those big groups. So it was kind of funny. I had a little flashback. Like that was the start of a streamlined process with leadership for us to look at things from a whole different perspective, right? Because we're all about staffing these cases, doing these. They do reviews, we do 48-hour reviews, then we would do monthly reviews. Now we have developed into critical incident debriefs with the Tennessee Public Safety Network. I mean, it was like that was our foundation. So seeing that picture brought me back to reminding myself when I know better, I'll do better. Because I'm emotionally charged. That's my staff, not gonna mess it, right? They did not. Those are my officers. Those are my friends. Those are people I grew up with. And because of working through that whole process, we were able to take my red ball and get it out the top of my head and put it up under my feet at one point. But I think we have to work with our staff on both levels. Like as a leader, yes, you've got to staff it. Yes, you've got to protect them. Yes, you've got to work through those pieces, but you also have to recognize they're human, right? Because when you have a worker that says, I messed up today. Say, okay, how'd you do? You don't create that environment of psychological safety where they can come and say they think they know something. Well, you just tell me about it. A lot of times I'll take them out in the parking lot with you as well. You talk to me, tell me what's going on, so nobody else. And so they'll tell you, and he's like, no, wait a minute, you messed up. Or are you just being too hard on it? What other things affected that situation, taking that step back? And it's like, I really thought I messed up. If you as a leader don't create that environment for the staff, then you're not going to have improvements, because when we know better, we do better. And I think having the opportunity to start at the foundation of this process and continue to grow it over time has immensely over the last 10, 11 years had an impact on my leadership.
I think what Mary Beth's describing is so important to this idea of psychological safety. It demonstrates like it's how you experience your team. It's how you experience your interaction with your supervisor. And it's something that the sort of the team has to create. It's a shared experience. And so it takes active work like that to model it, to create a space for somebody to talk about a mistake in a safe way. Like you have to actively engage in that work to create psychological safety.
I think the benefit of this psychological safety, I know it was born out of fatality review, but when you look at across the total system, I know for Tennessee that deaths are probably under 2% of our total CPS cases, but I think it benefited psychological safety and interpersonal safety of our work when we experience those out of property staff cases. How we're doing those huddles. We did a lot of those tools that were introduced initially, and so I think it built and strengthened our teams. And so now, like Mary Beth, you can walk with your staff outside your staff, and they break down in tears. If a child passes away on the case level, and so they have to understand. You can be really honest with them. Unfortunately, baby's going to die, but that our points in our process is that we can put preventive measures in, so hope it doesn't happen. But when it does happen, we can be there, lock in as a team. So I think it has benefited across the entire system. I think that's one great benefit.
Yeah, that's so important. And I was trying to, inartfully, I think, make that connection earlier where, an organization's culture lives in its habits and how it solves problems. And so when you have this one big problem, child fatalities, and your response to solving it is to be reactive and punitive and blaming and shaming, which is for sure how we have been historically in places like child welfare. I mean, it was not very long ago that, this has happened since actually in Illinois and West Virginia, but in a very high profile way, 4 child welfare professionals were put on trial in Illinois County after a death on the caseload. They were subsequently acquitted, but there was a Netflix documentary. It was a very high profile shaming and to the point of charging criminally people who just wanted to take care of kids and families. And so when you have that in a system, then you can't build habits, the other part of it, that are reflective of that same sort of ability to go outside, the ability to get together, huddling. Sean mentioned this idea of just like building in spaces to build psychological safety and create habits. All right, so we're talking about a review process that's related to quality improvement. So talk about how this sort of now best practice kind of approach that grew out of Tennessee's work helps you. You said you know better, do better, like identify these opportunities and how it's helping you as a system go work on some of these improvement opportunities.
This is currently under a metamorphosis in Tennessee. And it's new in terms of a aggregate national model of data collection. But with Tennessee, it started, it's grown, it's changed, it's moved, it's changed, and now we're into a reform cycle again. And I think part of that is knowing what avenues you have already at your disposal. Not everything, I think one thing that would make anyone a good employee is knowing when to take something to your boss and when not to ring their phone. And so if we take every single item, hey, there's communication errors and issues going on out in, Roane County. Thank you. Of the 95 counties going on, who doesn't? Know which things to take up and which things not to. Sometimes there's a CQI. You can run it that route. There's some things that you do need to run up to ELT. I know Deshaun is on one of our ELT work groups around safety with firearms. That has come straight from this work recently. So I think there's something to say for knowing when to not overring the bell and when to take the right avenues. I think use the avenues that are at your disposal, as well as there are some things that don't require, we love, how do I say this? We love a working group. We love a working group. We love a round table with 500 people at it. Some things really are just an email. And you can solve a lot of problems if you just email the right person sometimes.
I think the scientific approach that you're describing is called a whack-a-mole approach to quality improvement.
Yeah,
Like something pops up, let's hit it. Something pops up.
yeah. I think sometimes we over committee what is something where there is one point of responsibility that we can reach out to for help. But as far as identifying those, the tool really kind of does the work for you. It's then what you choose to do with it.
Well, sometimes we as leaders don't take the opportunity to take the data and look at what applies to us, or maybe some of us do. But that's a pocket, right? We don't do it across the state. Deshaun and I were part of an initiative because we didn't have that communication with the ME's office. And so the majority of our cases, the autopsies were performed at the medical examiner's office in Memphis. And so we went and sat down and had a conversation. And now we're Facebook friends. We are like all kinds, because we set up a system that if you get a child under the age of 18, email these specific people, they will get back with you. We get the intakes put in, it included a hotline person, it included us, and then we knew what was going on. And then they would say, you have a history, because part of the Department of Health reviews required to know if DCS. So we facilitated that on our own just because we knew it had been identified. We knew it, we just needed that for reinforcement. And we still have and maintain that. Did we do that anywhere else? Well, no, because Deshaun and I was over in the flatlands, West Tennessee, where everything, the wind blows quite a bit here lately. But that was our work. We had enough work to do over 3 a day some days. But we would really work hard at building those relationships. But when it came to homicide in Memphis, they ain't gonna talk to them. They keep all their cards to the chest. Deshaun managed to wiggle his way in for that. Got him one contact that would give us just enough that we could proceed on. So we reached out then to TBI and developed with the West Brand TBI unit a relationship of let's talk. We sit down, we had a lunch together, all of us, all their agents and all my leadership. And so we were like, we have got to do better. Y'all can hold all the cards you want to your chest, but you're going to have to show your hand at some point, because I have these other kids. If you don't tell me what's going on, then these other kids have the potential to go home or to never be put into safety we have to talk. And so I think as leaders, we have that responsibility to take the data, look at it objectively, and then come up with a plan on how to fix it. Because what worked for us in Memphis might not work in Nashville. It might not work in Knoxville. It might not work in Chattanooga. It might not work in Washington or Greene County. But at least we tried. And we tried to bring the right people to the table. Sometimes as a system, we want to do 15 things at once instead of one thing at a time. We'll eat the whole pie. Don't slice it up, eat it one bite at a time, eat the whole thing. No, we need to learn as leaders to take the information, take the data and use it to the best of our ability.
Part of what I'm hearing you say is culture each strategy and record.
All day, it's so funny.
And I think CQI.
Yes,
CQI is going to be very strategy, methodology driven. Good. We need folks. We need that lens constant. But that still gets back to a relationship. At the end of the day, if you know the person you answer, don't. If you get a random email saying, "Would you like to be on a committee?" No, I don't.
but I'll do it anyway.
If Deshaun or Mary Beth do, yeah, absolutely. I'd love to. So I think that resonates on multiple levels, including for our CUI.
So tell me then, we did the origin story, and I'm sure I didn't know this came from there. With Bonnie on, right? You're in a good company. Talk about how Tennessee has benefited from being a part of this national peer-to-peer learning. Talk a little bit about what you think you benefited from, and maybe some things you'd like to see improve or get better, or the opportunities you'd like to see.
I'll say in the current state, which is just about what I can speak to. There is just an unbelievable amount benefit in being able to call you or people on your team and say, "Hey, we're seeing this in Tennessee. Do you see this elsewhere? Is this just us?" It's comforting when you say, "No, it's not just you. This is happening." And it's also sometimes, "Oh, we have something we need to work on." And you go, we've seen that before, but that's not a super common one. That also hurts my ears to go, "Okay, let's dial in a little more." That is one massive benefit. Not just you, but also all the other states who are taking this book this way, using the same team, using the same tool. If you go to contact them, I know what commonality does rural Tennessee have with LA? Actually, a lot. And we are learning and talking about things the way that they integrate their prevention on the front end of their hotline. We're talking about we're having some of those early discussions now, simply because we met these people through the partnership. I think that's one huge benefit is just it's kind of a pseudo way of the aggregate. Talking to those who are the owners of all.
I didn't mention that we use a platform called Basecamp that allows, if you're not familiar with it, but it allows people like us to just go on and pose a question to 40 jurisdictions and someone will answer. It's been a really nice tool for the community.
The other aspect I'd say for the partnership is this created tool and this shared tool. We could not sort through all that narrative data. And I don't know that we would want that much narrative data because you're really turning up the bias the more narrative you mix in. And so having a way to score it out gives us a way to tangibly and quickly get to action. It happens if we score it this month, it's going up for next quarter's review. We can get moving so much quicker rather than reading small novels each case. That would be my short, long answer.
Well, and I think having seen it from beginning to end, because we did not have this before, it was always punitive. Why didn't you? Why didn't you? Why didn't you? Why didn't you? Well, I don't know now. It's been 2 years. I don't know what I had for breakfast yesterday. I'm not sure I slept last night. You're asking me about something that happened 2 years ago. This is a little better system with not a why didn't you, but how can we? You know, that sentence of we is a sentence all unto itself, right? Because we can do better when we do better. And I think this gives us that opportunity to be able to use the data that's given to us to find ways to make it better without standing there pointing that nasty finger, forgetting that 3 of them are coming back at us. And as Austin said, CQI is great. I think sometimes, because I did CQI for a while too, my whole stint of 30 years, and all kinds of stuff, but we don't know, sometimes we don't give people things for CQI. We let them come in and come up with their own topics, right? Sometimes I wish we had a way to funnel that out and like foresee us use our CQI team to go, how do you build better collaboration with law enforcement, or CACs, or each other, or in the office, or morale, and then actually do something with the ideas that come to us. Instead of it turning into, this is about me and my business. About the whole agency as a whole with a mixture of that, not the 500 people that Austin wants to bring into the room, like we always have to do, but making very small groups that are representative of different disciplines to say, how can we do this? Can't streamline a process if we are not all involved. Yes.
I was just kind of to that point, have we either in Tennessee or nationally started extending the we beyond the child welfare agency? So I'm just thinking about some of the examples with the police. What would the police say about that? Do they have a reason for rushing or? So, and even with these reviews, is the systemic stuff coming from a tight group that was involved with the case, or is it broader? I can see that we'd start to want to broaden, and it might get overwhelming. But I'm just curious, maybe that's in the improvement part as opposed to the analysis.
Yeah, we have some examples of jurisdictions that partner better with places like law enforcement and are able to bring them in. And in some of the reviews, you might bring in law. You can, that step of going and doing the debriefing, fit into it, debriefing law enforcement is very involved. I was just involved in a case where we were kind of walking alongside the jurisdiction and we debriefed the highway patrol because they were involved in the case. So we definitely are bringing in information from other settings when it's possible. There are some, just sometimes it's just something. There's also a tool that we use around which now you guys use this or don't use this, but there's a mapping tool that we use. It's kind of adapted from an accident cause analysis. It's called an AXIMAP. And it's meant to allow you to bring in like another set of eyes who weren't involved in the case. And it's usually mapping across a set of, like you've seen safety planning gaps across, it just keeps recurring. So let's go map it. And that allows you to bring in a broader set of perspectives. And it's a real system. Again, it's like a process and a QI tool that leads to an output. But part of the reason is we created this new center and it's called the Center for the Helping Professions and not the Center for Child Welfare Quality Improvement or whatever we might have wanted to name it, is the recognition that we need to get out into other jurisdictions. And so we're actually kind of actively working on, can we replicate this model? We have one in mental health that we're trying to spin up. We were actually going to pursue a law enforcement grant that was specific to law enforcement to do a similar sort of model in law enforcement, but that's been put on hold. So yeah, I think that's the next phase of this, hopefully, is again, like using this data to further the narrative that child welfare systems can't be responsible for this stuff, and they need better support and they need a better recognition that this is a cross-sector responsibility, not just one system. Did I answer your question? I feel like I said a lot of words.
Can you include providers in these reviews?
Again, it's really, we don't exclude anybody. It's up to the jurisdiction, like the review team, who they think they need to identify. So I haven't done one in Tennessee in a while. Yeah, or a treatment provider. I think it's completely appropriate if the case indicates it.
And then the second question is, have you considered extending this beyond child death to parent death? We're looking at the causality, the opportunities there, and identifying
Yeah.
their
We encourage jurisdictions to apply.
shortfalls as
Yeah.
far as service.
We encourage jurisdictions, because of the nature of the data, you could do it on anything and the data would be valuable. So we encourage jurisdictions to push this as far as they can with their QI work. There's resource limitations, like these reviews are kind of labor intensive. So like I use the example all the time of, like LA County has a whole division. Arkansas has one person. So, in Arkansas, they've got to just do deaths because that's all they can handle. LA County actually does a lot. It applies to a lot of different. So, I mean, it really is just kind of a root cause analysis approach. It's not unique to fatalities. It could be used in a lot of.
We do invite providers to speak into those cases. It's not often that it's hard for them to fill. A lot of times, even if we say, we promise it's really, really safe and we're not here to, go for it. And so we do extend that, and that doesn't often result in the interview.
Well, I think there's probably some fear with responsibility and accountability,
Yeah.
and I didn't think they quite understand the process. Happening.
I was, just thinking about psychological safety, because I'm one of those that are pretty comfortable. Meaning that it express my thoughts and feelings without fear of retribution or punishment or whatever, but a lot of people are not. So how can some of those lessons that you all are learning in terms of child death, how can we extend that further to the child welfare culture, workers that don't have a case that's centered around child welfare, just where they can be comfortable making mistakes, feeling comfortable coming to them. Some of the things that she's been hurting, but how can we kind of spread that abroad so workers or frontline professionals feel more comfortable in committing that? I don't know what now feeling like they're inadequate job based on those fears and the lack of psychological safety.
I don't know that I don't know if there's a written way to do that. And how do you spread that? It's there again, it goes to we. I think a lot of it has to do with the team. It starts at the top. It starts at even Deshaun's level as assistant all the way down is to be able to add that. And then there has to be a willingness, not just of leadership, but of the field staff to be vulnerable. Because there are just some folks that I don't care what you do, they are not show any emotion. They are the people you don't play poker with. Because I mean, they're gonna win every hand because you can't tell, you can't read them. But I think it has to come over time. And I think it has to be a determination, not only of the worker to be willing to accept that, but as the leaders themselves to be able to create it. You can create it at the top or you can create it at the bottom. CQI gives them that opportunity to be able to push those things forward. And it's something that we can always explore through different avenues to create those environments. So I think it'll always be a challenge. It's been a challenge for 30 years. Had great supervisors, I wouldn't tell them to go kick rocks. I did my job and don't.
I would say from the managerial experience side, that was also answer from the technical side, make a CQI referral. My director reads every one of those and I staff every single one of those with her every other week. And we formulate a response to all couple hundred of them that we get. We take those very seriously. I know it feels like you're sending a form stack into the void and when anything ever returned to me. It really should. So we do. I know it feels like you're kind of launching a little email to nowhere. It's coming to me. We care about those greatly and we got a great idea from your experience. We want it.
Sorry. So you talked about like the learning opportunities in other jurisdictions in other states. How do you see the information that you're gathering from these reviews
falling into that space of prevention, and how do we move the state forward in this focus of maintaining children safely at not bring kids into care? What are the lessons learned and how should that being shared through the system as we try to change that culture?
You can have a whole 3-day conference.
So what we're learning in Tennessee?
I'll say right now, there's a few initiatives going on current that I'm very excited about from part of this work. Some of the FFPSA, Family First Prevention Services, that's coming out. It starts off very functional answer. Enough beds to help do it, enough people and services, and demand and supply is really a big part of it. And so we've expanded, by expanded, I mean, double some of our intercepted MST programs in our 15 counties that have the highest rate of putting kids in our camps. So that is the number 1 and 2 and 3 and 4 answer in terms of what we're doing here in Tennessee, is we're pouring our resources towards that front door. And that, when the creek don't rise, will have trickle down effects to our caseload, to our quality of work, to
Beds we need.
number of beds we have downstream from there. That front door obviously is kind of the beginning of all. That I would say that'd be my really short, again, whole 3-day conference on prevention strategies that happen in Tennessee, but in the data that we're seeing out of it. But I would say that is probably first and foremost what we're focused on.
I didn't know if there was like if there was enough information or enough data potentially, like in looking at like that community and the collaboration piece, like if we were at a point where we had enough information, you know, to be. We know from the work that we're doing that like just that learning curve, that opportunity to gather information on resources, but you know, just in terms of do we have data behind that, and we can some of that discussion as we're doing our work in partnership with DCS even around how do we build stronger partnership, collaboration.
I would offer that it's something that, again, developmentally, as far as growth we do, that we want to be able to do, and Tennessee would be a place where we have a lot of Tennessee data we can control on. But not just doing I put that weird figure up, not just doing like aggregating the data at the state, at the national level, but bringing our skill set to a state and helping them, look at their data when they have enough of it. And Tennessee happens to be a state that has enough now. Not most states don't. So we hadn't really thought about that from exactly that perspective, helping the state with aggregate. If I understood your question. Sorry.
Yeah.
Well, thank you all. I think we are at time.